Nitin sir, thank you for a fabulous talk actually. So what do we actually call true Minokas? It is the patients who don't have an obstructive lesion but subsequently turn out to have a ruptured plaque or an erosion on imaging, or and we also do we include the scared patients? So I mean, what constitutes true Minoka then, sir?
Yeah, correct. So you have a Minoka and you have got Minoka mimickers. So Minoka mimickers where there is a non-coronary or non-ischemic cause of troponin leak presenting like an ACS. So those are all those Takotsubo, myocarditis, sarcoids and all those things, or even but the thing is, the one which is purely vascular related would be either the embolisms as I showed you, or could be the plaque erosions, or or even the even epicardial spasms, so and so forth. So the basically, but you should know the target vessel to do the imaging. So there the MRI comes in handy because it forms almost a central position in the evaluation. So moment you have a troponin high and normal coronaries or non-obstructive coronary disease, I think best thing is to get an MRI. You will have non-vascular causes ruled out, and you will also know the target vessel to be imaged because you have a subendocardial scar in a particular territory like you saw in the circumflex territory. So you know the target to look for an OCT, and despite that 15% of the patient will not find anything. The OCT is negative, the microvascular function study is negative, and also the MRI negative.
Nitin, just one point that, the way the myocardial infarction is, uh, what is it? Oh, question. It's from me, not from up. Myocardial infarction classification. Class 1, we know it is due to the obstruction, atherosclerosis. Will you call this as a type 2 myocardial infarction then?
No, there has to be a reduced supply, not increased demand. There has to be reduced supply by something or the other way. So either by the coronary emboli or the coronary pathology, but which is not being picked up by the regular coronary angiogram. So there have to be a supply reduction. But the problem is that in a clinical presentation, you have got these mimickers where the myocardial leak may be a non-ischemic pathology. So that we'll have to first sort it out before the coronary imaging.
Nitin, one question for you. We see many a times patients who have classical or maybe non-classical chest pain, discomfort, and echo-wise is showing generalized hypokinesia. And when you do the angiogram, the coronaries show significantly slow flow in these arteries. So are you going to predict what is the cause of these particular patients as far as the slow flow is concerned by MRI or what the PECT?
I think that's a very common occurrence that we see. So probably it is related to the increased microvascular resistance that we are seeing this epicardial flow slow. So I think the MRI can give you the myocardial characterization, and definitely you may find some reason for it. You may find an increase in the extracellular volume, tell you that there is a lot of extracellular fibrosis, and that's why probably the microvascular resistance is high, so and so forth. But I think these are the ones where we should be doing very actively the microvascular function studies. I think probably we have to develop that culture in the cath lab to do the microvascular functional studies, both by acetylcholine challenge also, and both by measuring the IMRs also. Most of the cath labs are equipped with it.
So one question for Dr. Sharma is that many a times we see, and we have done the MRI studies, the SPECT as well as the PET FDG, and they show that the area is non-viable. But when you subject these patients for multivessel angioplasties or for CABG surgery, we find the area which was supposed to be non-viable has recovered fairly well over the course once the surgery or the PCI is done. Your comment on that?
See, the dysfunctional segment improving has been reported. Now, you are measuring different part of the, you are measuring different thing in PET scan, you are measuring different parameters in MRI. Now, viability also is a viability, and non-viability also is it's quite a range. A dysfunctional myocardium or a non-viable myocardium also can have a myocardium which is jeopardized, a myocardium which is infarcted, a myocardium which is viable. So when you are grossly measuring it, still there may be a lot of discrepancies. And that's why these, what we are seeing some discordance, that sometimes what you have labeled as non-contractile or non-viable have been shown to improve after revascularization. That's why the last slide, because of the lack of time, I didn't this thing. There's a big meta-analysis which came after the Stitch trial, this thing, that sometimes even the non-viable myocardium can improve.
Question for Satyavan Sharma, sir. Sir, your talk was great, and thank you for conveying your message exactly on time. The question is, I do concur with you that even in cases where the viability is very low, the long-term prognosis is excellent. We see that in surgical cases. For instance, I have had a considerable experience of left ventricular aneurysm resection, where that particular myocardium is not only not viable, it is actually scar. You excise the scar, and we see that these patients have got good 10-year, 15-year survival post resection of the scar. Similarly, post-infarct VSDs, when usually anterior VSDs, there is a abrupt closure of the LAD, and we don't graft that distal vessel because the rest of it is all repaired. And these patients also, we are seeing good 10, 15-year survival post the surgery. So I do agree with you that this area needs further investigation, and that we should not give up any cases as non-viable, that these patients will definitely have a poor prognosis long term.
The paradigm, will change. Now, I think guidelines will change or may change. There will be a paradigm, how you choose your patients, whether you should choose on the basis of viability only, or whether you should have each and every profile. I think we'll have to individualize some cases, looking at the vessel caliber, the age of the patient, the kidney function, the presence or absence of there may be a patient where there is maybe a lot of viability, and you find this patient's vessels are extremely bad, He may not benefit from CAVG or from PCI despite having a good viability. On the other hand, maybe a patient where there is a non-viable myocardium. This is a young patient, he has got very good caliber vessels, and maybe this patient is the one who may benefit. So I think by these two trials, why I use the word disruptive, I think we have to think in a completely different way than what we were thinking. And what these trials, and when you read them a little more in depth, is what is being told is that all the data which we were talking in the last 30, 40 years was based on small, non-randomized observational trials. That's why we will have to think in a different way.
One quick question for Dr. Burkule. One question.
Actually, before that, I will request, Manish is doing a lot of this thing, so I especially requested him. Manish, make your comments and then we'll
Thank you. So, first of all, the Stitch trial was heavily criticized, but at that time, the imaging modality was used is low-dose dobutamine stress echo and a SPECT scan. It did not include the latest modality, which is PET scan and cardiac MRI, which has got much higher ability of picking up viable and non-viable myocardium. Even in that dobutamine stress echo, which has been included, the subjects included were when there were more than 5 segments, which are like becoming ischemic. But actually in clinical practice, we have like ischemic burden more than 3 segments, and that considered to be like significantly benefiting from revascularization. So Stitch trial, although did not show statistically significant improvement in terms of like viability, but if you do the sub-study and sub-analysis, there is significant improvement in patients' functional classification and heart failure reduction as well. The other thing is we are looking for the different modality. Cardiac MRI is the best investigation as far as I feel, because you can do simultaneously low-dose dobutamine in cardiac MRI, which you would not be getting in PET scan. There is always a debate about PET scan better than cardiac MRI. But if you look at the contractile dysfunction, you can assess this by doing a PET MRI, cardiac MRI with a low-dose dobutamine. Although we have a limitation in availability and expertise, but what I would suggest is that low-dose dobutamine stress echo with myocardial contrast echo would equally give you the good results. So I would say viability is still a very important and powerful modality. It depends on the expertise availability and the modality of investigation available at the local center.
I
Sir,
think
we-
Ashwin, Satyaman, I feel the best indicator of viability is angina. If you talk to patient, spend some time with him, if he says he has got angina, forget about everything else, just get his revascularization done.
I would take that up
sir,
a
we
little
have
bit.
to end
Can I
now.
just take
One question. Last question.
Okay. I will just take that up. If he gets angina from an RCA and he has a totally occluded LED, how does that justify LV improving if you grab the LED? I go back to 25, 30 years ago in my experience at Leicester. My surgeons refuse to not graft any artery that is occluded. He said, it's occluded, we are going to put a graft to it. You guys don't know what you're talking about, they'll all do well. And they did, yes. Stormy post-operative course, but when they came through, excellent results. So I think it helps to think simply. Graft and come out.
You have to select a good surgeon.
No, sir, I think we'll have to end,
Sir,
please.
Sir,
No,
one
no,
question.
no.
One very important question. Dr. Tulpule, why Minoka is more common in females? Is the release of troponin same when there is Minoka or when there is macrovascular disease?
I really don't know the answer to that, but I think women probably have more burden of microvascular dysfunction. But I really don't know the answer why Minoka is more common in women, but definitely it is very much more common in women.
God has made them differently, I suppose. So, thanks for a wonderful, wonderful session. We have a tea break after this, but we have another very interesting session coming up, the last one of the day, and that's again on ischemic heart disease and interventions with very practical topics. So requesting all to stay for that session, which will then be followed by dinner and everything. So 20-minute break, please. Thanks.